All right. Hello, everyone. Hope everyone is doing well. And we will get started in a few seconds, just live streaming to YouTube.
All right. Hello, everyone.
Hold on a sec here.
Hope everyone.
All right. Well, it looks like it's working on YouTube. So, yeah, I had to do it a different way. The way I usually live stream to YouTube didn't work. And I think it's because I used the same Zoom link as I did the last time, so it started playing the. Anyway, I got it. Think I got it working. Let me record on Zoom as well. All right. Well, let's see. All right. So again, thanks for joining me on this Wednesday evening. Depending where you are, if you're in a different part of the country, it might not be the evening where you are. But anyway, hope you're having a good day, a good week. And so we're going to chat a little bit about overcoming hyperthyroidism. And really, the main reason I'm doing this is just to answer questions. I do have a very brief presentation, but extremely brief, but really just want to see what questions you had. I did this about a week and a half ago on a Saturday, not this past Saturday, but the week before, and had a pretty good turnout. So I figured I'd do an evening call though, just for those who were unable to make that Saturday call, or even if you were able to make it, but wanted to pop in again. All right, so just let's get through the announcements. Many of you already know I've been sending out a few emails that I will be having a free 5-day hyperthyroid healing diet challenge. And this will be starting on Monday, February 1st. So the way it works, I did something similar in August. It wasn't specific to hyperthyroidism. So this is going to focus on hyperthyroidism. And so every day you'll get a pre-recorded 10 to 20-minute lesson, as well as an assignment. So regardless of where you live, whether it's in the US or a different country, it doesn't really make a difference. However, there will be live calls on Facebook and Zoom, and this probably will make a difference. But what I'm doing is I'm going to be rotating the times to accommodate those in different time zones, just like I'm doing with this chat. I had one again during the day a week and a half ago on a Saturday, and I figured I'd do one in the evening. And pretty much the times will be similar. So the evening times will be, or evening times, my time will be 8:30 p.m. Eastern time. The day calls will be 12:30 p.m. Eastern time. They will be recorded as well. The Zoom and Facebook. I'm going to Zoom. I'm going to live stream to my new Facebook group, which I'll mention in a minute. If you want to register, you could visit hyperthyroidhealing.com. And again, it's completely free. And then there's a new Facebook group. So when you join, you'll receive a confirmation page. There'll be a link. Of course, again, you don't have to join the Facebook group to benefit from the challenge. But in the Facebook group, right now there's last I checked, 450 people have registered for the challenge, and about 200 and I guess like 220, 225s in the Facebook group. So about half of those who register on the Facebook group. So definitely not everybody who registers will be in the Facebook group, but there'll be a lot of engagement. There's already engagement going on, and we're also going to try to make it fun, having some prizes. So check it out. And so last Thursday, I released a blog post entitled 3 Reasons to Avoid Radioactive Iodine. So I figured I would just put, really, it's just a single slide, just kind of summarizing that. And if you haven't read that, I would definitely go ahead and do so. Now, the first reason most of you are familiar with, which radioactive iodine does not do anything to address the cause of the condition. So that's a big reason why many of you are trying to avoid radioactive iodine, because it's not, it's especially those with Graves' disease, it's an immune system condition. But even if someone has toxic multinodular goiter or another hypothyroid condition, again, the radioactive iodine isn't addressing the root cause of the problem. Reason number two, and I gave some research in the article that shows that the quality of life is actually worse in those who receive radioactive iodine treatment. So there was a study that looked at people with Graves. Well, actually, it might just be hyperthyroidism. I don't think it was specific for Graves. Again, it's in the blog post, but it followed people a number of years later and just showed that overall quality of life was worse. So I won't get into specifics. You could go into again, just read, and it's based on a journal article, that I forgot how many people were involved. I think about maybe like 1,100 people who received radioactive iodine. So, yeah, I'm not sure if all those, maybe it was 1,100 people, but just like, yeah, again, it's only been a week, but I already forgot exactly the numbers. But again, it's all in that blog post. And then reason number three is that radioactive iodine can potentially worsen, maybe cause thyroid disease. It's not really causing. If someone has, usually what happens is someone might have very mild thyroid eye disease, and they might, as a result, might not know it, and the endocrinologist might not know it. So the endocrinologist tells the person to get radioactive iodine, and they get the radioactive iodine, and all of a sudden, they have symptoms of thyroid eye disease. But chances are they had it prior to it, they just didn't know it. But then also, if someone already has thyroid eye disease and they do know it, if they have overt symptoms, it can make it worse. And that's why many times endocrinologists will not recommend radioactive iodine if someone has overt thyroid eye disease. But the problem is, again, some people have mild thyroid eye disease and will receive that. And, and then once they get the radioactive iodine, it gets worse. And it's, yeah, so those are the three reasons that I discussed in the blog post. For more detail, definitely check it out. I also spoke about whether surgery is a better option, because really, if the three treatment options, when you go to an endocrinologist, usually it's going to be anti-thyroid medication. And if for any reason, let's say you can't take the anti-thyroid medication, if it's, if you're having a reaction, or even if you're doing fine with it, and if it's, usually many endocrinologists will only let you take it for a year and a half or 2 years. So, and then they'll give the option for surgery, radioactive iodine. So again, obviously, the goal is to try to prevent you from getting either radioactive iodine or thyroid surgery. But, given the choice, it's a tough call. And I talk a little bit about it if you're considering, because even in the Facebook group today with the Hyperthyroid Healing Diet Challenge, it was one person. We have an introduction post, and I've been trying to respond to everybody who's introducing themselves. And one person pretty much said that she's looking to get thyroid surgery. She just hasn't done so because of the pandemic, just the circumstances. But it sounds like she's pretty set on getting it. But I guess she's still joining the challenge to see if she could improve her health. So in that case, she's getting so there are people, maybe even attending this call, who's thinking about radioactive iodine thyroid surgery. So again, I talk about not only avoiding radioactive iodine, but surgery as well. There are, of course, risks with surgery, risks with pretty much risk with anything, even natural treatments. I mean, there's it's to me, I'm going to be biased because I had Graves and got into remission. But natural treatments, not the risk as like radioactive iodine thyroid surgery, but there's risk that maybe it doesn't work, or you're taking herbs to try to manage the symptoms. And like bugle weed is something I took, and it worked well. And many of my patients have taken it over the years, along with motherwort and some other natural agents. But again, sometimes it is a challenge to manage the symptoms, and that could be risky. You don't want uncontrolled hyperthyroidism. And then, so the last bullet point on the slide before we get into Q&A, and for those who have questions, feel free to start typing it in. You could type it in if you're on, those on Zoom, just type it in the chat. And for those who are on YouTube, same thing, just, go ahead and type in your questions, and I'll get to them in a minute or two. But this last point about taking low doses of antithyroid meds for a prolonged period of time, there is some research, and again, I'm pretty sure I'll present that research in a blog post, where It's more common in other countries, countries other than the United States, but some endocrinologists are opposed to radioactive iodine and really don't want the person to get thyroid surgery. So they'll have someone, if someone's tolerating the medication well, again, methimazole, PTU commonly will cause side effects, elevated liver enzymes, white blood cell count, low white blood cell count, and then other side effects like rashes and dizziness. And again, I talk about some of these in the blog post as well. So if someone's experiencing those symptoms, of course, they probably, even with lower doses, they probably wouldn't want to take it. But if someone's tolerating it well, and again, ideally want to address the cause of the problem. But if we're just talking about these three treatment options, radioactive iodine, thyroid surgery, anti-thyroid medication, some people actually do well with low dose, like 5 milligrams of methimazole, let's say, long term. Again, not ideal, but something else to consider. So, all right, well, like I said, it's a very brief presentation. So let's go ahead and start typing in questions. And also feel free, if you want, to let me know where you're Zooming from, or if you're on YouTube, let me know where you're watching it from on YouTube. And let's see. All right, I'm going to take a quick sip of water before I get to the chat. All right, and if, all right, so Monica says, thank you. You're welcome, Monica. Okay, so Ketra asked, where did I get your bugleweed supplement from? So there's, bugleweed, of course, it's not like other supplements. There's not a lot of options just because it's specific for hyperthyroidism. So I took, the bugleweed I took was from MediHerb, the company MediHerb. A number of my patients take Herb Farm. That's another option. And MediHerb is more potent. So Herb Farm, both MediHerb, Herb Farm, good quality. Herb Farm is a 1:5 extract ratio, whereas MediHerb is a 1:2, so it is more potent. But there are some people that do fine on the Herb Farm. All right, so there's a few, and sometimes it could be intentional, sometimes it could be a mistake, but some people will send me a private message on Zoom. So what I'll do is I won't mention the person's name, but I will read the question so everybody could benefit from the question, or at least I'll try to remember not to. I'm so used to reading people's names here, so I'll try my best. But anyway, so let's see. So this next question, which again, this is private. The next couple are private. So this is fantastic. I'm new and wish to ask if heavy metals has been connected to hyperthyroidism. My naturopath said I tested extremely high, understand situations that would cause this. So heavy metals in the literature, there is a connection with Mercury and Graves, like thyroid autoimmunity, Graves and Hashimoto's. There's nothing that shows Mercury directly causing hyperthyroidism. On the other hand, it can potentially cause hypothyroidism, like directly, but it can also affect the immune system and be a factor. And then, there's others like aluminum has not been shown in the literature to be a factor with hyperthyroidism, Graves' disease, but it definitely is an immune stimulator, has been associated with autoimmunity. And then, there's other heavy metals, but less, again, not a lot of research showing like arsenic, for example. There's nothing that I've seen. Cadmium, I think again, I've written some articles on this. I wish I could say I remembered all the research I do, but it's on my website. You could do some searching for heavy metals and mercury, but mercury is definitely a big culprit. So now that being said, if you have I work with a lot of patients who have mercury amalgams in their mouth. That doesn't mean that mercury is going to be a trigger. So not everybody I work with, actually probably the majority of people who have mercury amalgams don't get them removed. And most of them still get into remission, which tells me that the mercury is not the main trigger. But there are people where they won't get into remission until their mercury amalgams are removed. And there is a test. There's a few different tests, actually. There's Cyrix Labs has their Array 11, and then Melisa, Melisa, I believe. They look at the immune reaction to heavy metals such as mercury. So if someone has mercury amalgams and let's say they're not improving, before, I mean, of course, you know, you could go to a dentist. If you go to a dentist, go to like a biological dentist, make sure you get the fillings removed, you know, with the proper precautions. But you could also do a test like the Melisa or Cyrix Labs and see if you're actually reacting to the mercury. So that's something to think about. But again, check out, if you go on my website, naturalendocrinesolutions.com, there's a search bar. You could do a search for mercury, silver fillings, heavy metals, and you'll come across some articles. All right, so this is another private message. So I have toxic cyst and considering radioactive iodine treatment, subclinical hyperthyroidism, so no medication. So thyroid hormone levels are okay, but I'm guessing the TSH might be on the lower side if it's subclinical. So can the cysts, which are solid, be reduced? It depends on the situation. I've worked with people with cysts, you know, and with nodules, cysts. Typically, the two big factors, and I've written some articles on this too, so also check out them on my website. But estrogen dominance, even, you know, whether it's women or men, you know, I know us men don't like to hear about estrogen dominance, but it could be in men or women. But insulin resistance, estrogen dominance. So insulin resistance, you know, you could look at that in the blood, you know, what like not, I mean, glucose, single fasting glucose won't really tell you if you're insulin resistance, but you could, you know, get a glucometer and measure it daily. You could do fasting insulin, hemoglobin A1C. Estrogen metabolism, a little bit more challenging to test for. So in the blood, you could do, I mean, there's estradiol that many times comes back negative, which is good. But then there's also total estrogens, which is something next time you get a blood test, you might want to consider testing for, see if that's high. And then there's dried urine testing, something called the Dutch test that is a real good test for estrogen metabolism. It's not a cheap test, but I've had success in some cases. Again, it's you know, some cases they'll, you know, people do a follow-up ultrasound like 6 months later and they'll see a good reductions in cyst nodules. But then there's cases honestly where the person doesn't respond. So, you know, I would say, I mean, the good news is subclinical. You know, if it's causing any other problems like any type of obstruction, then I can understand either radioactive iodine or surgery. If you have some difficulties breathing or you know, swallowing, then, you know, then it might be, you know, understandably, you know, where you want to take action sooner than later. If that's not the case, I mean, there's also the concerns with, of course, you know, cancer, you know, and again, sometimes I'll do biopsies. And I also wrote an article on that too, like when is a biopsy necessary? It depends typically on it is solid. So that when they're solid, greater risk, but then also the size. So if it's solid and greater than definitely 2 centimeters, some will say 1 centimeter, you know, but again, then a biopsy, it doesn't mean that it's cancerous, but then that's when usually a biopsy may be indicated. But yeah, you know, also read the article too, because again, even if you choose conventional treatment, you know, I mean, in your case, it's not grave, so at least that last the last point I brought up about the thyroid eye disease probably won't be a factor about, you know, getting that. So, but, you know, still I would check that out. And, you know, again, radioactive iodine versus thyroid surgery, not an easy decision to make, but again, I would read the full blog post. And if you have any follow-up questions, definitely let me know. All right, so Jessica, can COVID cause thyroiditis? My TSH was very low 3 weeks after COVID. My TSH has now normalized. I have tested negative for TSI and TPO. Should that be checked as well? So interestingly enough, I think it was in September, I wrote an article on COVID. I forgot the title. The title is like, coronavirus 19 and thyroid health, like an update on coronavirus 19 and thyroid health. Um, and yeah, there is research from, I think it was July. It's only a few months after learning about COVID, but there have been some studies that COVID can cause subacute thyroiditis. And I actually, I did so I'm doing a challenge next week, a 5-day challenge. I did a 21-day challenge in November, and there was someone who was part of that challenge who had hyperthyroidism, and it seemed like it was due to COVID. She got COVID, got subacute thyroiditis. So yeah, subacute thyroiditis, viruses are typically the cause, but yeah, COVID, of course, the COVID-19 new here, so we just, the research didn't come out until the summer, but yeah. So as far as should that be checked as well? So I'm not sure what you're asking, because you got, I assume you tested for COVID, since you said your TSH was very low after getting COVID, and then TSH is now normalized. You have tested negative for TSI and TPO. Should that be checked as well? So I'm not sure because it sounds like you checked for TSI, checked for TPO, tested for COVID. So I'm not sure what else. What I would say with subacute thyroiditis, and we'll talk a little bit as far as the diet, but remember it's still immune system, even though it's, not Graves. With viruses, whether it's COVID, whether it's Epstein-Barr, whether it's cytomegalovirus, you still want to do everything you can to improve immune system health. All right, Ketra is from Michigan. All right, and Jessica from California, Jonah from Washington, and we got someone else zooming from Pittsburgh, Pennsylvania. Okay, so here's so this question, I'm not sure, Nayung, I'm not sure if hopefully I pronounced your name right. Let me just do a quick check to see. So far, there's no questions on YouTube. So if there's any questions on YouTube, let me know. I'll check every now and then the chat in YouTube. But all right, so why is methimazole not preferred for long-term, or did I hear that incorrectly? Doctors in the United States aren't crazy about methimazole. They're concerned about the effects on the liver, but that's why you test the liver enzymes. You do a comprehensive metabolic panel or just a hepatic panel, look at the liver enzymes, do CBC, complete blood count, make sure white blood cell count isn't too low. So if liver enzymes looking good, white blood cell count is looking okay, and if the person is doing fine, if they're tolerating well, they're not getting symptoms due to the methimazole. Again, it's not doing anything for the cause of the problem. So ideally, you want to try to do that. But if someone, if someone's struggling to address the cause of the problem, then again, it is a potential long-term solution. And there are some endocrinologists that will do it in the United States. There are just some that, just 18 months, 2 years, if you're not in remission, they'll recommend radioactive iodine or thyroid surgery and will no longer write a prescription, for the methimazole. So, but you could always try switching to another endocrinologist, of course, if that happens. But yeah, so I'm saying just, you don't see a lot of that. I do see patients who have been on methimazole for longer than 2 years. Again, there are some endocrinologists, and then, some people will take the methimazole for 18 months or 2 years. They'll be in remission temporarily, which really, to me is not true remission, but everything will look good, and then they'll relapse. And then sometimes the doctor will put them on another like 18 months to 2 years. But yeah, in some countries, and again, some places also in the United States, or some endocrinologists in the United States will also put someone on like 5 milligrams of methimazole and just say, okay, just stay on this because at least you could keep your thyroid and not get the radioactive iodine thyroid surgery. And yeah, I mean, another thing with the radioactive iodine that I didn't mention about the 3 reasons to avoid it is, some people, I mean, there are people who get it and they do okay. Not everybody, of course, has side effects, but there are some people that it's real, like the endocrinologist will say, well, you just take the pill, you just take radioactive iodine, or you just take radioactive iodine, and then you just have to take a pill, thyroid hormone replacement, pretty much levothyroxine for the rest of your life. And a lot of times it's very challenging with the dosing, and some people just don't do well with thyroid hormone replacement. I mean, some people don't have a choice to take it, but again, it's not always that easy. So that's I didn't really talk. I don't know if I spoke about that at all, but that's yet another reason to just not necessarily jump into the radioactive iodine. Okay, so Arsenia from Los Angeles, California. What can I do or drink for high antibodies from the thyroid? So yeah, nothing really you could drink. I mean, yeah, for the high antibodies. So the question is, why do people have high antibodies to begin with? With Graves' disease, or even Hashimoto's or other autoimmune conditions. So there's something called the triad of autoimmunity. So there is, so 3 factors: genetics, which of course we can't change genetics. We can't, switch around your genetic predisposition or change your genetic predisposition. But fortunately, then the 2 other factors, environmental toxins, and then, or I'm sorry, environmental triggers. So 1 is genetics, 2 is exposure to 1 or more environmental triggers, and 3 is an increase in intestinal permeability, a leaky gut. So you want to try to remove your triggers. And I talk about 4 categories of triggers. 1 is food, such as gluten, dairy, corn. And we'll talk about these, next week. So again, if you haven't registered, for those who might have trickled in late, let me bring up this slide here so you could, if you want to check out the free challenge, we'll be talking about diet. So we'll be talking about food triggers. Number 2, stress. 3, environmental toxins, and 4, infections. Those are the 4 main categories of triggers. And so you want to, to look, and again, sometimes it can be challenging. That's why you want to do as much as you can through diet and lifestyles. And that's why I'm having this challenge, is because it doesn't involve, spending, money on testing or taking a bunch of supplements. So it's pretty low cost. So, definitely good place to start. But some people do need to dig deeper. And, I have some articles on lowering antibodies on my website too, but pretty much that's what you would be doing, is just trying to remove triggers, and then also healing the gut. And with the gut, if someone has a leaky gut, again, you want to remove the factor that's causing a leaky gut. So if someone's eating gluten, and if that's causing a leaky gut, they would need to remove gluten. If someone has a gut infection, such as H. pylori, that's causing a leaky gut, or a parasite, then they, of course, would want to address that. All right, so Candace, thank you, Dr. O. My thyroid numbers normalized except for the antibodies. Is this remission? No, so the antibodies, yeah, if and some endocrinologists don't pay attention to the antibodies just because they're not really doing anything for the immune system. But yeah, if thyroid, if TSH looks good, free T3, free T4 looks good, but antibodies are still high, then that's not really considered remission. Remission, in my opinion, is everything is normal. So that's yeah, that's really true remission. That's why a number of people relapse, is because their antibodies are still high, but the endocrinologist might, I mean, and again, some do look at the antibodies, but a lot of them will just test the thyroid panel, and then, then, of course, they're going to base the dosage of the antithyroid medication. If the person's taking antithyroid medication, they'll base it off of the thyroid panel. But sorry, just got a little message about my Dropbox. Yeah, so you really do want antibodies to be normal. All right, so Young has another question. Can TSH alone determine Graves, or are there multiple symptoms that need to be found in order to diagnose, and can amalgams bring on Graves? So I mentioned earlier about mercury amalgam, silver fillings potentially being a factor. And I would definitely visit my website, naturalendocrinesolutions.com, and search for silver fillings. I do have an article where I spoke about specifically, there's a few articles on mercury, but specifically silver fillings where I talk about mercury amalgam. So it is a possibility. But I also mentioned how there are people who have mercury amalgams who I work with. They don't get them removed and they get into remission. So yeah, TSH alone cannot determine Graves' disease, because if someone has a depressed TSH, they could still have like toxic multinodular goiter. They could have subacute thyroiditis. They could have what's called hashitoxicosis. So so typically Graves' disease is diagnosed by depressed TSH, elevated thyroid hormone levels, unless, I mean, there is subclinical hyperthyroidism, but most of the time it's depressed TSH, elevated thyroid hormone levels, and elevated TSH receptor antibodies, with the most specific being TSI, thyroid stimulating immunoglobulin. So that's really based on the diagnosis. That's really what endocrinologists use to diagnose Graves' disease. And then, yeah, symptoms are, not everybody has the classic Graves symptoms, but some common symptoms are increased resting heart rate, palpitations, sometimes weight loss, but again, some people will gain weight, increased appetite. But again, that's what those symptoms are, what hyperthyroidism. So that doesn't mean Graves' disease. Now, if someone has eye symptoms like hyperthyroidism and eye symptoms, then a pretty good chance they have Graves, because with Graves, a lot of times, not everybody, but a thyroid eye disease is something that is common. All right, John says hello from New Jersey. All right, so we have now a few more private messages here. How to overcome doctors who maintain that the only way to check thyroid is with a blood test. I mean, really, there's nothing you could do. You're probably not going to be able to talk. If that's what they do, then that's what they do. So well, I would say this. I mean, thyroid, that is how you check the thyroid, is the blood test, but they might not want to do more than a thyroid panel, or some of them just want to do TSH and free T4, not free T3. Others don't want to check the antibodies. And of course, many aren't looking at other factors like vitamin D, as in David, which, that's important for not only bone health, but for a healthy immune system. And then things like looking at adrenals, like through the saliva or dried urine, and nutrient deficiencies. So, I mean, for doctors who don't do that, there's really not a whole lot you can do, probably, because, they just do what they do. They're probably not going to want to listen to you. They probably won't want to listen to me either. And, so really the best thing to do is just either switch to a different doctor, or just do the testing on your own if you have to. Okay, so another private message. Is there a way to detox from it? So I'm not sure. Do you mean the mercury? Like, are you referring to the mercury earlier? And should TGA be tested for too? So I'm not sure what you mean TGA. You mean thyroglobulin, like thyroglobulin antibodies is what I'm guessing you mean. Usually it's like anti-TG, but the A, maybe the AB is usually the abbreviation for antibodies. So if that's the question with the so yeah, not a bad idea to test for like TSI, definitely diagnostic of Graves, but it's very common for people with Graves to have antibodies for Hashimoto's too. A lot of people with Graves have TPO antibodies, and I'd say probably like 25% to a third of people have thyroglobulin antibodies. It usually is not going to it's not going to change the approach. I wouldn't say it's absolutely necessary. It's with autoimmunity there. Now symptom management will differ, of course, if someone has hyperthyroidism compared to hypothyroidism. But if someone has the autoimmune response, it's not going to really change much as far as how I address it. And if you talk about mercury, if you're not talking about mercury, then I guess you could clarify in the comments. But as far as detox, I mean, you want to try to remove the source of the mercury. So if you have mercury amalgams, you're always going to have some. I mean, regardless, you're going to have some, I mean, everybody has heavy metals, but you know, if you're really trying to greatly reduce and minimize the mercury in your body, you know, and if you have amalgams, you want to remove them. And then, yeah, once they're removed, I mean, even before they're removed, you don't want to get too aggressive. Like some will get chelation therapy. You definitely wouldn't want to do that while you still have amalgams. But if you're doing things to increase in glutathione, which is the master antioxidant that supports detoxification, so you could do that, like, you know, just in general. I'm not saying specifically you should do this, but sometimes I'll have patients take like a NAC, N-acetylcysteine, or a liposomal acetylated glutathione. Infrared sauna is really good for sweating out the toxins. All right, Jackie says hello from Chicago. Hello, Jackie. Yeah, we love Chicago. So if you're originally from there, I'm originally from New York, so I can't say I don't love New York, but I don't miss living there. I'm in Charlotte, North Carolina, so I definitely enjoy living in North Carolina. But yeah, we really like to visit Chicago. Been a few years since we've been there, though. Okay, so Nat Young, your name is Natalie, so maybe Natalie Young, is that what maybe that's what that stands for. Okay, thanks Natalie for letting me know. Okay, so George, thanks for response on the cyst, not taking insulin, estrogen not insured to my knowledge, but no other indications of issues. Cyst has been reduced, drained about 15 years ago. Suspect, although solid, they start out as fluid filled as well, non-cancerous. Thanks again. We'll check out your site once more. Yeah, and just to clarify, I wasn't not that as far as insulin, I wasn't saying that you're asking if you were taking insulin, although if you were, then if you were taking insulin, it'd be due to probably type 1 or maybe even type 2 diabetes, and then that would correlate with insulin resistance. But even if you're not taking insulin, like a lot of people have insulin resistance and they don't even know it, like it's they're pre-diabetic, for example. But yeah, so what I was saying is test for insulin, do a blood test for fasting insulin, make sure it's fasting. Sometimes also a lipid panel, just cholesterol, LDL, HDL, triglycerides. Sometimes very common with insulin resistance, the triglycerides will be elevated. So if you've had a recent lipid panel, now again I think you were subclinical. I was going to say with hyperthyroidism, sometimes that will affect those markers, but yeah. So look at a lipid panel, fasting insulin, maybe hemoglobin A1C, and then yeah, I mentioned total estrogens. All right, and this is private. Okay. So thank you for answering my questions. I joined your challenge. I'm new to hyperthyroidism and feel so lost and scared sometimes. Yeah, well, thank you for joining the challenge. I'm sure you'll learn a lot. And again, we'll be having live calls every day. It'll be a little bit different. So like this format will be pretty much, I'll be streaming to not to YouTube, but to Facebook. But then like Monday, so again, there'll be daily lessons, but then also there'll be live calls, and Monday, Tuesday, Wednesday, and Friday, there'll be specific topics for the live calls. So here I gave, a very brief presentation. I'm not saying there'll be lengthy presentation. So maybe it will be a little bit similar, but I'll pick up, a topic to talk about, maybe a little bit more in depth, but I guess it really depends on the topic. I might not go into, I honestly haven't really prepared the presentations. The recorded lessons are pretty much done, but the live calls, I haven't put together the slide, which actually I guess I have to do because we're only 5 days away. But so I'll have to work on that this weekend. But yeah, definitely. And then on Thursday, a week from tomorrow, there will be 2 like Q&A sessions. So kind of like this, where there'll be 90 minutes and opportunity to answer questions. So is there a way to detox from COVID causing subacute thyroiditis? So that's what you meant by the detox. So, I mean, you don't really necessarily detox from viruses. Again, I know there's like for Epstein-Barr and cytomegalovirus and herpes simplex, there's homeopathy that people could take specifically for those. But so far, there's nothing I know of for COVID. I mean, there probably will be eventually something for COVID-19, like a specific homeopathic formula. But, and again, maybe there is, but from the company I use, there's not. And yeah, so, but I would just focus, do everything you can to improve immune system health. Again, diet, lifestyle play a big role. So the challenge will greatly help you. Healthy vitamin D levels. Again, I mentioned that earlier, getting sufficient sleep, which again falls in the lifestyle, sometimes supplementation. So a lot of people this year or, last year until this year, taking things like vitamin C and zinc and those could be helpful. Those, just, I mean, you got to eat well though. If someone's like eating a poor diet and taking vitamin C and zinc, then it's not going to work as well. But yeah, with all viruses, I mean, and there's obviously we're always going to be viruses. COVID is a different threat, but there's always risks of viruses, even though arguably COVID worse than other viruses, but still, you always want to, and there's, I was having this discussion with my teenage daughter that, again, they very well might be, a lot worse viruses, a lot more deadlier viruses in the future, so, really the best defense is just doing everything you can to improve immune system health. It's not perfect. It's, there's, risks with, there's different options. Of course, the vaccine, is being distributed and, that's up in the air as far as, it's a new vaccine and, but everything's risk versus benefit. So, just, either way, whether or not you, my goal is not to really, talk about the vaccine, but, whether or not you choose to get the vaccine or you don't get the vaccine, you still want to improve immune system health. You want to still have healthy vitamin D levels. And again, it's not going to hurt to, take some vitamin C and, some zinc. I wouldn't go crazy with the zinc, but hope that helps. And may I ask you if you witnessed certain emotional traits that seem to be more pervasive with your hyperthyroid patients? Some, I would say, some people anger. I mean, everybody's different. So, but anger. But then some people are more despondent, more depressed. But I'd say probably anger, anxiety, definitely. Is pretty common with hyperthyroidism. And at least that's what's coming to mind now. If anything else comes to mind, I'll let you know. I'm going to take another quick sip of water. All right, so Jonah has a question here. Newly diagnosed with Graves on 15 milligrams a day methimazole. Taking that, I'm guessing, for 3 months. Mild side effects, lowish white blood cell count. So, so not too low, I'm guessing. Blurry vision. Okay with low dose of methimazole, but want to transition to supplement natural alternatives in addition to diet and gut work. Where to start? How might a transition look? Time frame? Good Graves naturopathic or doctor in Seattle area. Yeah, I'm not sure about the last question. I'm not sure. I wish there were more doctors that focused on Graves. So yeah, I'm not sure about one that's in the, I guess you could just do a search, which you might have already done, like, Graves doctor, Seattle, and see if someone other than an endocrinologist shows up. But so if someone's taking methimazole, and if they want to get off, I can't tell them to stop methimazole, just like I can't say like for you to stop it, and not that you're asking, but usually what I'll do is, if someone wants, I mean, everybody wants to get off eventually. Nobody wants to be on methimazole forever, but if someone like, just specifically says that they're not comfortable taking the medication and they want to, they're looking to get off of it. Again, I won't tell them to get off, but I'll usually put someone on bugle at the same time as the methimazole. Now, again, they might not take it at the same time as the methimazole, but we'll have them, take both the herb and the medication, and then monitor the blood test. And as the blood test, if someone's on both of them, the hope is that they'll be pushed more towards the hypo side quicker, which some people don't want to hear, but that's really what you want. You don't want to be like super hypo. I know some people will take methimazole and they'll be like crazy hypo, and then sometimes the doctors will panic and they'll stop the person, or they'll dramatically decrease the dose and the person will be hyper again. But so we're not looking for that kind of hypo. We're looking like a shift more to the hypo side, and then then the doctor will decrease the dose, let's say from 15 milligrams to 10 milligrams, and then maybe like a month later do another blood test. So it could take a few months. I mean, some people do it quicker. They just kind of do it on their own. Again, I don't tell them to do this, but they might take the bugleweed and then, maybe they'll just wait a month, do a blood test, and if things look good, they might stop taking it. Again, I don't tell them to do this, but usually, yeah, I would say, just, you want to, every, month or so do a blood test if you're doing it that way. And then, as the numbers look better, eventually they can make the transition where they're just on the bugleweed. And then eventually you want to be off the bugleweed. I took bugleweed when I was dealing with Graves, but I haven't taken it since 2009. So the goal is not to be on bugleweed for good. And then again, for diet, definitely tune into the challenge, as well. And, gut, sometimes you have to do other things for the gut, but, try to do as much as you can with diet. All right, let's see. And, all right, so still quiet night on YouTube. So, last time when I did it on a Saturday, we had a good amount of questions. Definitely more on Zoom. We always have more on Zoom, more people attending on Zoom than in questions. I mean, attending on Zoom than in YouTube. But let's see. Okay, well, these next few are, again, private messages. I don't know if they're meant to be private, but again, I'll try to remember not to mention people's names when they're private, but I'll read the question. So going through listening here, but I have hypo for 23 years and Hashi's for 5 years. Okay, so yeah, so you might want to check out my book, Hashimoto's Triggers, which is on Amazon. It's a very comprehensive book, which most people like, but some people they get a little bit overwhelmed, but you don't have to read it from front to cover. So yeah, so I mean, there's definitely overlap between Graves and Hashimoto's. The symptom management aspect differs, but again, the autoimmune response, there is a lot of overlap. But like so on my website, I mean, lately the emphasis has been on hyperthyroidism, especially with the hyperthyroid challenge. But there's also, articles, blog posts on hypothyroidism, Hashimoto's. And again, the book that I wrote, released about 3 years ago, Hashimoto's Triggers, got, really good reviews. And so it's not just my bias, of course I'm going to be biased, but again, it seems like a lot of people, do like it. And again, you could get it. There's a hardcover edition, but there's also a Kindle version edition for $6, which is not too bad. And it's like, again, it's a big book though, like 500 plus pages. But as I said, you don't have to read the whole entire thing. So, and you said you had hypo for 23 years and Hashi's for 5 years. So my guess, I mean, I could be wrong, but you probably had Hashi's for longer than 5 years. It probably was just diagnosed 5 years ago. But many times the doctors won't test antibodies. But who knows, maybe you had antibodies tested and they were negative and then they were tested again. But if they weren't tested, 5 years ago was the first time they were tested and you were diagnosed, you probably had them for quite a long time, would be my guess. All right, so next question, is magnesium worth adding into my supplement regime or regimen? So yeah, I would say magnesium, it's one of those that it's not, if for any reason you don't need it, it's usually not going to hurt. Most people, if they take it, they don't need it, they'll get loose stools. But a lot of people are magnesium deficient. So if someone's having like constipation, they might want to take magnesium citrate, magnesium malate, and magnesium glycinate, also really good. I would try to stay away from magnesium oxide. All right, so I don't think anybody has asked me this question. What is your best treatment testimony or story? Would love to hear. Oh boy. I don't know. I mean, I have on my website, I do have a testimonials page, and you could look at Google reviews. Believe it or not, I like to tell one story I like to tell is not my testimonial, but it's a lesson. So I would, for testimonials, I would visit my website and you could judge which one you think is the best one. Um, but one lesson I learned, so this was a number of years ago, and I tell this story a lot, where a person was seeing me, a male patient was seeing me with Graves, and he seemed to be getting better. Like he seemed, was feeling pretty good, and thyroid panel was actually looking better, but TSI would not normalize. It was remaining high, and this was like 7, 8 years ago. So I know better now for what I'm about to tell you, but his gut health seemed pretty good. He had no gut symptoms, no digestive symptoms, regular bowel movements. I mean, everything seemed okay. So, I was hesitant to recommend a comprehensive stool panel because, symptom wise, he was fine. And, they are pricey. So, I just spoke with him and I was telling him, we could do more testing, but the testing I was thinking of, I didn't think would come back positive. And I just, you know, um, again, I wasn't sure, but long story short, he went to another practitioner and he got a comprehensive stool panel. And the only reason I knew this is because I followed up with him about 6 months later. I sent him an email. So he emailed me back and he told me, he said he saw another practitioner, he got a stool panel done and they detected a parasite and he followed a protocol and, a anti-parasitic protocol, got rid of the parasite and TSI normalized, got into remission. So again, I feel sad sometimes when I tell that because it's not my success story, but it taught me a lot not to rely on, you can't always rely on symptoms. A lot of people over the years have said, well, my gut is feeling good. And I don't recommend comprehensive stool panel on everybody. So that's not the point of this story. The point is that, again, you can't just go by symptoms. So if someone comes and sees me, and we might start with, I'm very conservative with the testing, unless if I feel the person needs more comprehensive testing, I'll recommend it. Or if the person just wants comprehensive testing. But again, my goal is not to have people spend like a few $1,000s worth of tests or, a few $1,000s on tests. So, but if we start out with, like some blood testing and adrenal testing, and I do like hair testing, if we're not finding answers, then, regardless of the symptoms, you could also retest. There is a chance. That's another thing, like retesting versus further testing, and that's even what, get into the parasite example. There are people who will follow a parasite protocol, and sometimes it can be difficult to eradicate. So they might follow a protocol for parasites, let's say for a couple of months, and things don't get better, and they assume, oh, well, it wasn't a parasite because I followed a protocol, but they never retested to confirm that. And the parasite, upon retesting, the parasite was still there, and then so we had to take a different approach. So it could get challenging. It's that's why I'm going to be biased and recommend for people to work with a natural healthcare practitioner, but it's because even with the natural healthcare practitioner, it could be challenging, but especially doing it on your own could be really challenging. But again, to be fair, there's some things you could do on your own, and that's what next week's about. That hyperthyroid healing diet challenge is, again, that's you taking charge of your health through diet and lifestyle. All right, so Jonas says thanks, and okay, and then so the person with hypothyroidism for 23 years and Hashimoto's for 5 years, and so she again sent a private message just saying that it was the first time that antibodies were tested. So my guess you had them for a long time. All right, so thank you. If my thyroid labs continue to come back normal, but I'm still having symptoms of anxiety and palpitations, could this be adrenal fatigue? I just changed my diet about 6 weeks ago too. Could this be linked to the gut? So, I mean, to answer your questions, yeah, adrenals definitely could be a factor, and yeah, anxiety, depression. There's a psychiatrist, a functional medicine psychiatrist, Dr. Kelly Brogan, who's written a book, or I think she's written a few books, but one that talks about depression, anxiety, and she talks about gut health. So if someone's having anxiety, maybe palpitations, I mean, gut, but anxiety and gut health, depression and gut health, there definitely is a connection between gut microbiome and, anxiety and depression. um, and so yeah, I do recommend with most of my patients looking at adrenals, but yeah, you definitely can't overlook the health of the gut as well. And that's another lesson too, that some people, when they think about the gut, and gut problems, they just think about digestive symptoms, but you could have other symptoms linked to the gut. You could have, again, anxiety, brain fog, neurological symptoms in some cases. So yeah, thank you for bringing that up. All right, so wow, on the comprehensive stool panel story, I respect you telling that. Yeah, so it's, again, I think it's a better story than me raving about. Again, you could just visit my testimonials page and you could read the, again, I mean, the thing is also, I mean, the bummer is, there's probably better stories that people just don't, like, again, not most people who get better don't give testimony. I mean, that's just how it is. Like, probably you too. I mean, I'm like that too. Like, I can't say I've given Google reviews and testimonials to everybody I've had a positive experience with. It's just, that's just how we are, but so there's again, there's a good number of success stories and, Google reviews that are positive, but there, a lot of people have good experiences, but on the other hand, when people have a negative experience, that's when, they're more likely to give, again, not on my website, because, but on like reviews and stuff like that. But anyway, so yeah, I do like to share that story because it is a good lesson. All right, so let's see. Serene, I don't know if I'm pronouncing your name right, but is it Serene or Saran? Saran, hope I'm pronouncing that right. So I've never been diagnosed with thyroid disease, but I have a swollen neck, I have nodules. What test should I do to get answers about my thyroid? So, well, I mean, I would get a full thyroid panel, TSH, free T3, free T4. I would get antibodies, as well. I would not wait and see if thyroid panel, because what a lot of times what will happen is thyroid panel, like doctors will look at a thyroid panel and it might be within the lab range, but outside optimal range, and it could still cause a goiter in some cases. So I would still recommend looking at the antibodies. I mean, more so with Hashimoto's though, like usually with Graves, if someone has elevated TSI, thyroid stimulating immunoglobulins, usually they'll have elevated thyroid hormone levels. Although I said early, some people could have subclinical Graves, but I would look at the antibodies. I probably would test all three antibodies: TSI, thyroid peroxidase, and anti-thyroid globulin antibodies. You might also, I mean, I'm guessing you've done a thyroid ultrasound. If you have nodules, I mean, some endocrinologists, especially if the nodules are larger, they could detect them through palpation, but most of the time they're going to be doing an ultrasound, especially if they suspect nodules. If they palpate and they think there's nodules, they're going to, yeah. So I'm guessing you had a thyroid ultrasound. So if you're having nodules, swollen neck, now again, there is multinodule goiter, which multinodule goiter, a lot of people are euthyroid, meaning T3, T4 are looking good. TSH may or may not look good. Check out that article that I wrote. Do a search on naturalendocrinesolutions.com for multinodule goiter. But again, that problem, usually estrogen dominance, or problems with estrogen. Problems with estrogen metabolism or insulin resistance. Sometimes iodine deficiency. Iodine is, of course, very controversial. Some people don't do well with iodine, and so. But check out some of the information on my website. All right, so Natalie, I'm having a rhinoplasty in April. Can this cause an issue with hyperthyroidism and Graves? I don't think so. I can't say I've had a lot of patients get a rhinoplasty, so I don't think that would cause a problem. I mean, definitely, check with the surgeon, but I mean, I guess I'd be concerned. I assume they're gonna. I'm not sure, but I'm guessing they're doing like general anesthesia, which probably still will be okay, but definitely, I assume you probably ran it by your doctor. So I don't think it'll be an issue. I don't know 100%, but definitely check with the doctor, and your doctor might say the same thing. Well, I haven't worked on a lot of people with hyperthyroidism Graves, and I'm not sure, but you'll probably be okay. But I still would ask. All right, so I just had my endorphin and dopamine tested via the urine. Is it worth asking on my cortisol tested as well? Maybe even my DHEA? Yeah, I have just about all my patients test cortisol and DHEA either through the saliva or dried urine. Okay, so Saran also is a challenge for folks who may have hypothyroidism too. I mean, it's not really specific for hypothyroidism. I mean, it's some of the information will benefit people with hypothyroidism, Hashimoto's, as well. So I can't say that it's only like 100% information will only benefit people with hyperthyroidism. So, I mean, it's up to you. I mean, usually when it's not the first hyperthyroid I had last year, last June, I had a 21-day hyperthyroid challenge. And there were some people with hypothyroid. I mean, again, just about everybody was hyperthyroidism, but there's always a few people with, just like in this chat, the chat's a hyperthyroid chat, but there'll be some people with hypothyroidism that kind of trickle in and like, oh, I might as well just check it out. So some of it I won't be talking about hypothyroidism. The only exception might be is if someone has, like if they have hyperthyroidism, but if they, maybe if they have some like fluctuating symptoms or something like that. But again, we really won't be focusing on like specifically hypothyroidism, Hashimoto's. But like I said, there will be overlap with some of the recommendations. All right, I'm gonna go, depending on how many questions there are, I will go another like 12, 13 minutes until 9:45. So let me, all right, you are welcome, Natalie. All right, John asks, do nodules exist in both hypo and hyperthyroidism, or is it only common in one or the other? No, we see it in both. Yeah, it is common in both hyperthyroidism. So I probably see it more in hyperthyroid patients though, but you could definitely have it with hypothyroidism. All right, all right, I'm gonna, so let's see, there's, okay, a fat hug to everyone. It's all gonna be okay, peace, I agree. So there's so far 3 questions left. So there might be others, but I'll definitely get through these 3. And then we'll see if there's any other, again, up until like 9:45 my time. So Ketra, can changing your diet to vegetarian trigger hyperthyroidism? Yeah, no, it usually won't trigger, but vegetarian, like if you're eating an unhealthy vegetarian diet, and of course, like gluten is, gluten, dairy, if you're not vegan but vegetarian, dairy is allowed. So if someone's eating a lot of gluten, which you could eat with any diet, not just vegetarian, but if you're, the main thing you're doing is like avoiding meat, meat and fish, that's not going to trigger hyperthyroidism. All right, Jonah, are there different supplements, herbs for thyroid eye disease? Selenium are the same ones that you recommend for Graves. So, I mean, first of all, remember, thyroid eye disease is an immune system condition more than an eye condition. Just, like Graves is more immune than thyroid. So there is a lot of overlap, and the supplements are similar, but a lot of times I'll get more aggressive. Like I might give higher doses. Selenium, you do want to be careful with, but like a standard dose would be like 200 micrograms, but some people with thyroid eye disease might do better with larger amounts, like 400 micrograms. Again, there is risk for toxicity. Same thing with like if someone's taking curcumin, they might take 500 to 1,000 milligrams on average, but if someone has thyroid eye disease, they might take higher doses, like a few thousand milligrams, and things to help with glutathione. And yeah, so there are a lot of similarities, but dosing sometimes will be higher. But again, key is to remove triggers, heal the gut, correct underlying imbalances. If you don't do that, the supplements, they could help to some extent in some people, but you always want to address the underlying cause. All right, so this is again a private message. So 62-year-old female overcame Graves 10 years ago through amalgam removal, developed heart palpitations after possible COVID infection this past March, elevated thyroid peroxidase and thyroglobulin antibodies, normal TSH, elevated CRP, which is C-reactive protein, was using ashwagandha, came off, using bugleweed and L-carnitine. So what to test for next? So all right, so let me look at this again. So overcame Graves, so 10 years ago through amalgam removal. So you got your Mercury amalgams removed 10 years ago, got into remission, but then got COVID this past month and developed heart palpitations. So elevated thyroid peroxidase, thyroglobulin. So, I mean, I definitely would test, I still would test TSI, thyroid stimulating immunoglobulins, for, just make sure it's not Graves relapse. I mean, that would make sense. You could have all three antibodies. It's not uncommon for me to see people with TPO, thyroglobulin, and TSI. And then, yeah, it is odd though that TSH. I mean, if I had to guess if TSH is normal, TSH is normal. I guess, if it's normal, like between 1 and 2, then, if it's like less than, like if it's on the lower side, then even that, usually Graves is like really depressed TSH, but I still, just to rule it out, I would get TSI done. I would do T3, T4 if you haven't tested the thyroid hormone levels. Yeah, so CRP, but again, with the possible COVID viral infection, I guess the question also, like if you had subacute thyroiditis, like I mentioned earlier, COVID, the research shows that it can cause subacute thyroiditis, but that usually it normalizes after a few months. So was it normal TSH right after, like in March, or did you wait like 3-4 months or longer and then it was normal? Because it could have been subacute thyroiditis, which presents as hyperthyroidism, but now is kind of normal, but you still have the autoimmune, so we know there's an autoimmune component. There's elevated thyroid peroxidase, whether or not it's Graves or not, like you have elevated TSI, regardless, we know it's elevated TPO, elevated thyroglobulin antibodies. So, so you still want to, with blood testing, I get pretty comprehensive. So, it's up to the person, of course, but, you might have already done the basics like CBC with differential, comprehensive metabolic panel, lipid panel, 25 hydroxy vitamin D. I would definitely test vitamin D. I would do B12. You did CRP. I would still maybe do blood sugar, might be fine, but, like fasting insulin, homocysteine, if you haven't tested homocysteine, Epstein-Barr, speaking of viruses, like doing Epstein-Barr. When looking at Epstein-Barr, there's 4 markers. There's 3 IgG markers and 1 IgM marker. Usually the IgM will be negative, but every now and then it'll be positive. So I would test for all 4 of those. And then if you're not 100% gluten-free, I would also do a celiac panel, just because you never know. Even if you feel fine when eating gluten, you could have silent celiac, or you could have non-silent celiac too. But if you're eating gluten, you can't test for gluten if you're not eating it. If you've been gluten-free for definitely like a few months, you can't test for. And then if you want to dig deeper, go beyond blood tests. my patients, typically I'll do the blood testing I mentioned, but then also I'll look at adrenal testing. I like doing hair mineral analysis. Some practitioners don't like doing that, but I've been doing that for, it's all comes down to an interpretation. But those are what I would look at. Those are the starting points in my patients. And then, depending on the case history, health history, I might recommend other tests, but when I was dealing with Graves, that's what I didn't get a ton of tests either. And that's probably why I don't typically recommend a ton of tests. I got adrenal saliva test, hair mineral analysis, blood testing. And so so those are the starting points, I would say. So thanks for the question. And let's see. Are there, okay, I read this question before, so I'm going to go another like 5 minutes here. And you are very welcome. So, okay. So is there prolonged thyroid issues after subacute thyroiditis? So with subacute thyroiditis, typically what usually happens with subacute thyroiditis is someone will be hyperthyroid for, like 2 to 4 months average. It could be longer than that, but average of 2 to 4 months. And then after that, it will be, a lot of times they'll swing to hypothyroidism. And the hypothyroidism usually is temporary. Sometimes it can be permanent. Most of the time it'll be temporary, and then they'll normalize. Would usually a greater likelihood of it becoming permanent if they have multiple, like, if, like you could have, just like someone could relapse with, they could have Graves multiple times. Same thing with subacute thyroiditis. You could have subacute thyroiditis multiple times, and every time you have it, you are more likely to remain hypothyroid permanently. But and again, COVID is new, of course, so we don't really know. But if it acts like other types of subacute thyroiditis caused by other viruses, such as like cytomegalovirus, then again, same thing. It should be more temporary. We'll find out, I guess, maybe as soon as this year, we'll see, what new studies there are, when it comes to, COVID and thyroid health. So, okay. So if there's any last questions, definitely let me know. Again, I'll stay on for another couple of minutes. All right, we got some private thank yous, and you are welcome. Okay, so someone else is in a lot of private messages. I don't know, sometimes it's not intentional. People just like, but either way, so someone else sent a private message. I'm in for the challenge, tend to resist Facebook, but can get a temporary account to join in. Thanks again for your time and effort. Yeah, that's a good point. I mean, we have for the challenge, a lot of people don't want, I mean, I'm not a big fan of Facebook either, especially with all the censorship and all that. But truth is, it's just still a lot of people with hyperthyroidism that need me are on there. And, it's, so it's a way to reach out to them. And it is that their groups are really good. Eventually, I'm going to take groups off of Facebook. Like I'm going to do more off of it, but for now, and again, it's on Zoom too, so you could do either one. But if you want the engagement with others and you want to, participate to be eligible for the prizes, have some fun, then yeah, I would say create a temporary account, and then you could just delete it once the challenge is over. We've had people do that with past challenges. So Ketra says, is oatmeal gluten-free? No, it's commonly cross-contaminated with gluten. So you definitely want to get not only gluten-free oats, but ideally, if you're going to eat oatmeal, like certified gluten-free oats, like Bob's Red Mill oats. I've had patients just have regular gluten-free oats, and they still didn't do well. Can gluten mimic the thyroid? Again, another private message. Can gluten mimic the thyroid hormones? I don't see research on that. I know some, like I think Dr. Datis Karazian talks about how there's like a molecular mimicry, between gluten and thyroid. Again, I don't think, again, I don't think it's just him too, but I think there's others who have mentioned that. So I don't know. I definitely would. I mean, gluten could definitely be a factor, though, when it comes to, thyroid health, thyroid autoimmunity. So, but that I'm not sure of. I've heard that, I've heard that a long time ago, but there's not a whole lot of research to back that up. But either way, just you want to, at least while restoring your health, trying to avoid gluten. All right, Dr. Osansky, thank you so much. You're greatly appreciated. You are welcome, Monica. Thank you. Thank you for attending, and everyone for attending. And John also says, thank you very much, Dr. Eric, for all you do and offering an option, a standard medical approach to treating thyroid conditions. Yep, you're welcome. I mean, again, if it wasn't for me, to getting into remission myself, I wouldn't be here. So it's, blessing in disguise. Of course, when I was dealing with Graves, I didn't look at it that way, but I realized that I could help others, and it's been over 10 years, and it's just been a pleasure working with everybody. And COVID, the one blessing in disguise with COVID, it pushed me to do more of these. I was very shy. I've been doing webinars for a long time, but hiding behind the camera. And so since since 2020, I've been doing more Zoom calls, more Facebook lives, more streaming into YouTube. So yeah, so anyway, it's I enjoy doing these, and and again, enjoy. I'll be having fun next week. I'll be tired at the end of the next week's challenge. Don't get me wrong. It's because I'm going to be seeing patients all week too. It's not going to be a reduced load, but it's fun. And it's also the 21-day challenges are a lot of fun too, but those are really draining. So the 5-day challenge, still a lot of work. The most work, honestly, is the preparation. Just like next week, it'll be, like I said, it'll be a little bit challenging, but this part is, to me, is easy. Like, answering questions and presenting, doing all the preparation work, all the prep work is hard. So and Jackie, sorry I missed the answer to the question regarding if this challenge is for hypo Hashi folks as well. So I mentioned earlier, it's not really specific for hyperthyroidism. There will be some overlap, so you're not going to hear me talking about, like, all the presentations will be designed for like hyperthyroidism, like Graves, toxic multinodular goiter, subacute thyroiditis. You won't really see things that me talking about specifically Hashimoto's and hypothyroidism. Some of the information you can benefit from, but probably the one after this, the next 5-day challenge, I'll have probably another 5-day challenge that it's not going to relate to diet. It'll be on a different topic, but it'll probably be, I'm not sure. Maybe it'll be like May or June. Then it might be more like, like for those with hypothyroidism, Hashimoto's. So if you have hyperthyroidism specifically, this is the one you want to attend. If you have Hashimoto's, hypothyroidism, you could still pop in. It's free, but definitely look out for the one after this. And all right. And Ketra said, you're really good at it. Well, thank you. Yeah, definitely room for improvements, I think, but yeah, thanks. I do enjoy it. I'm not as self-conscious as I was in the past. I just do what I do. And, I think I'm a better writer than speaker, but thank you, Ketra. And Lorena says, thank you. Really good information. You are welcome. So someone asked, where in New York are you from? So I was born in Yonkers, brought up the first 5 years in the Bronx, and then lived the next 20 years in Queens. And so I still have, my mother lives in Queens. My my younger sister lives in Brooklyn. And my father lives, he's, him and my mom aren't together anymore, but he's in upstate New York near Albany, called Cobleskill. So yeah, so I still have a lot of family in New York. Haven't visited them. Last year was the first time I didn't see him, which I know was the case with a lot of people, and again, a lot of people lost people. So I'm still grateful, but yeah, tough year for everybody, or a lot of people last year. But all right, well, I'm gonna go ahead and call it a day, or call it a night, because it's almost 10 o'clock my time. So let me go ahead and stop the share. And again, thank you, everyone. Hope everyone has a wonderful evening, or again, wonderful day if you're tuning in from Australia or New Zealand or anywhere like that. Have a wonderful day. Have a wonderful week ahead. I'm probably going to be doing another one of these on Saturday, just to let you know. So check out your email. I think I'm going to do one during the day, and then again, hopefully everybody joins the challenge, and you get a full week of me next week. So again, hope to catch all or most of you soon. Take care, and again, have a wonderful night.